Okay, well, welcome everyone. It is time for the latest edition of ACMT National Journal Club. Very excited for today's discussion with our colleagues down at WashU School of Medicine. Just before we jump right into it, a little bit of housekeeping. As always, if you're out there in the Twitter sphere, use the hashtag ACMTNJC. Between the articles that we're presenting, we'd love to get your comments, so raise your hand and we'll be happy to put you on the line. And also, of course, use the chat feature. We will be monitoring that. So without much further ado, I'd like to introduce our group down at WashU. We have fellows Ari Phillip, Michael Semple, and Dave Liss, faculty member, and their fearless leader, Dr. Evan Schwartz. So with that, I'm very excited about these articles. Why don't you guys take it away?
Thanks for that lovely introduction, and thanks for having us here. So this seems a very timely topic for us as we're running somewhat of a naloxone infusion service over the past about 4 days, it seems like. So we just thought these articles would be really interesting. We're not saying it's time to change practice necessarily, but just really interesting to have a discussion about a way that a different place manages their opioid overdoses. And I think one of the authors, who's an author on all three of the papers, is going to try to join in, so that'll be nice to hear their perspective and understand their system a little bit better. But with that said, I'm going to turn it over to Dave Liss, one of our faculty members, to kick things off.
All right, thanks, Evan. And thanks, Steve, for having us here. As Evan mentioned, just as a brief kind of introduction on why to do this, we have a lot of, it seems like we have a lot of poisonings with relatively long-acting opioids, and this journal club to focus on kind of what is the expected duration of effect on these patients, and then Ari and Mike are going to talk about some potential treatment options. So the first paper is from ClinTalks in January 2021. It's titled "Unintentional Buprenorphine and Methadone Poisoning in Children: A Matched Observational Study" by Dr. Farnaghi et al. And their stated objective was to compare accidental pediatric poisoning from methadone and buprenorphine in terms of clinical indicators and in-hospital morbidity. And for the methods that they used, this was a one-year study from March 2018 to March 2019, so this is pre-pandemic. And it's a matched observational study, and we'll get into that more later, on patients 12 years and under. Their buprenorphine cases were prospectively collected from ED admission and followed through their hospitalization. And the methadone cases were abstracted retrospectively during the same time period. And they used a matching procedure. We'll get into that next. But essentially, it's matched 3-to-1 methadone cases to buprenorphine by age and sex. So just kind of reviewing that matching procedure, this was done retrospectively. They had 170 methadone intoxication cases in pediatrics that year. So it was an extremely busy service for long-acting opioid poisoning. And they would include cases that were admitted within 72 hours of an index buprenorphine case. And they excluded those that could not be matched 3-to-1 by gender or age. The specific data that they wanted to abstract, their primary outcome was bradypnea and apnea. They also polled antidote administration, both initial naloxone dose and total infusion dose, as well as a gastric lavage procedure. Intubations, duration of hospital stay, presence of meiosis, level of consciousness on the AVPU scale, blood gas analysis, and mortality. This is a figure 1 diagram. So they had 200 eligible poisonings, 30 buprenorphine, 170 methadone during this time period. They excluded 80 all methadone cases, for 64 because they were not matched to the time window, or there was unknown intent or unknown dose. One was an intentional poisoning, which they did not want to include, and then 15 were not matched based on age and gender. So that left them 120 total patients, 30 in the bup group and 90 in the matching methadone group. And the outcomes that they observed, 20, and these are in both groups combined, 28 cases of apnea, 59 of bradypnea, 89 had decreased level of consciousness on the ABPU scale. All of them received naloxone. There were 5 resuscitations and no deaths. And pulling out their table 1 for the demographics, as you would expect in a matched group, the age and genders were relatively well matched, but so was the weight, which they did not specifically control for. And then they did their best to estimate ingested dose. And this wasn't a key point of the paper, trying to estimate the severity of intoxication based on dose, but they did their best because some of the patients, in the methadone group, they assumed they were all ingestions, whereas some of the buprenorphine had kind of a sucking or a sublingual exposure. But there was one big difference in the 2 groups, and that was time from elapsed since ingestion to ED presentation. Seemed to be significantly longer in the methadone group, which probably had an effect on their rates of gastric lavage, which they had acknowledged. Most of the medications came from family members, either parents or grandparents. There were some that were unknown. And then of the clinical characteristics that they identified, the groups were pretty evenly matched with outcomes, except for bradypnea and apnea. There was a trend towards increased bradypnea in the methadone group, and all of the apnea cases, 22% occurred of the patients in the methadone group had apnea, compared to none in the buprenorphine group. Another difference was the level of consciousness on the ABPU scale. There was a trend towards buprenorphine having a decreased overall level of consciousness. However, the methadone group had 7 patients that were fully unresponsive, and there were none of that severity in the buprenorphine group. Additional clinical characteristics that were different. Meiosis was significantly more common in the methadone group. And then as far as treatment, naloxone dosing was significantly greater in the methadone group, both the initial bolus and the total milligrams of infusion. And as we said before, the gastric washing, which probably had to do with elapsed time from ingestion. There were significantly more in the buprenorphine group, which had faster hospital arrival. Duration of hospitalization was longer as well in the methadone group. So they acknowledged several limitations. Estimating doses, especially of buprenorphine sublingual formulation, is difficult. They did not get serum methadone or buprenorphine concentrations to confirm exposure, although they did confirm with urine drug screens at least the exposure to the agent. The methadone group was retrospective, and we'll talk a little more about that later. And then one thing that I picked up on was trying to compare methadone and buprenorphine with morphine milligram equivalents is challenging, as one is a full agonist and one's a partial agonist. And then kind of the most one of the biggest limitations was, using logistic regression for two data sets that are collected differently. I mean, the computer program will do the analysis for you, but it's up to the researchers to determine if that's an appropriate comparison, if the groups were collected similarly enough to be able to compare that way. So thinking of that, you think about validity. So the buprenorphine patients were likely consecutive, but the methadone patients were filtered, and it's unclear exactly how they determined which cases would be included and which would not when there were excess patients above the 3-to-1 matching. In which case are they going to exclude, which are they not? And then the patients did seem to be similar in demographics, except for their duration of time until they made it to the hospital. There was a significant difference there. And then, surprisingly, some of the patients were not admitted. And so follow-up of that kind of situation is always challenging. You can say that you're going to look at coroner reports or check for readmissions, but that's always a difficult assumption to make, that all at discharge patients were completely fine and had no adverse events that you're trying to record. And then the methadone group was retrospective, which will decrease your risk of bias, but it degrades your data because you're relying on medical records, not research abstraction forms. And the buprenorphine group was prospective, but these were abstracted by an author who was leading the study. So again, there's a potential for the data may be more accurate, but there's also a potential for bias. So to conclude, or the conclusions they pulled, methadone patients were given larger doses of naloxone and higher infusion doses. Methadone was much more likely to cause apnea and bradypnea. Buprenorphine had a higher rate of decreased level of consciousness, but most of those patients were responsive to verbal stimulus. And although it wasn't statistically significant, intubations and CPR were only performed in the methadone group. And interestingly, all patients admitted to this hospital were on naloxone infusions, which was one of the things we wanted to talk about today. So I will pause here. I can't see the chat.
Yeah, thanks, Dave. There's nothing in the chat right now.
Okay.
So let's see. We do have one of the authors here, Dr. Hassanian Magadam. Are you there?
Yes, sir, I'm here.
Thanks so much for joining us. And again, I appreciate, you're an author on all three of these papers, and we know you folks have a large experience. Was there anything you wanted to share about this specific paper?
No, thank you. The presentation was excellent, and if there is any question, I'm happy to answer. But the thing that because we are not just working on the pediatric group, we are also working on the adult group, and probably the esteemed speaker will talk about it. But I want to stress on the fact that when the country are defining different opioid maintenance treatment, they shouldn't just focus on the patients themselves. They also should focus on the pediatric patients that are in danger of intoxication, especially for parents who are opioid dependent.
Yeah, absolutely. I think, we're all learning a lot with legalization of marijuana here in the United States. We're all seeing waves of pediatric gummy ingestions, and it's a mess. And but it is interesting, methadone versus buprenorphine.
You can speak, Dr. Blunt. Hello, can you hear me?
Yes.
So in terms, I'm Paul Blanc from San Francisco. I would say the paper as presented was pretty clear as to why persons who didn't end up being in the referent group were not in the referent group, it was because this was a time density matching and they were out of the time window. So I don't think the critique of it's not clear why they had more than enough to do the matching and why did people not end up in the matched group is to my mind, it's not an issue. I thought it was pretty clear. And in fact, there were just only a handful of people who were otherwise eligible for inclusion that were then excluded for some other reason. And also want to say that the statistical analysis was conservative in that even though these were methadone reference that were matched for age and time of event and gender, in fact, the statistics did not presume a paired analysis, which is the correct approach. These were treated as unpaired referenced. And most of their analysis was not logistic regression either. It was chi-square and t-tests and other things. So I from an epidemiologic point of view, I don't have any problem with study design in terms of the reference case selection. And also another thing to reassure oneself about is that the kinds of variables they were extracting, most of them would be noted in a pediatric emergency situation, such as the pupil size and the breathing rate and so forth. It's the problem when you do medical record extraction is if you're looking for things that people are likely not to comment on, or there may be a bias in why they comment on it, like bowel sounds or something like that, or skin, is the skin damp, that kind of thing.
Great. Yes, thank you. Wanted to, Dr. Zamani, did you want to go ahead and talk?
Hey, yes. Can you hear me?
Yes, go ahead.
Hello, everyone. Thank you, Dave, for a great presentation. I just wanted to mention 2 points. First of all, about administration of naloxone to every pediatric patient that comes to our institute. Yes, yeah, I do agree with you, but Dr. Fanari herself should explain about it. However, you can say from the total of the patients and their symptoms, many of them had meiosis, many had bradypnea or apnea. And so I believe many of them were really symptomatic and needed naloxone. And because of that, but I do agree with you that not all of the patients should receive naloxone. The second one is about, second point I'm going to explain to you is about the actually difference between the buprenorphine and methadone. Methadone is a pure agonist, as you know, and so patients are symptomatic easier and faster. So they're rushed to the hospital faster in most of the cases. On the other hand, buprenorphine is a partial agonist, and as you know, it doesn't cause respiratory depression just like methadone because it is a partial agonist. You know, most of the patients are drowsy, but they do not need a naloxone. And this is, in fact, the interesting difference between them. You know, the methadone groups needed naloxone in most of the cases, and because of that, they were more awake, but they had to stay in the hospital for a longer period of time because actually methadone was a pure agonist and it had a longer half-life. But the buprenorphine was a partial agonist, And, the patients needed to stay in the hospital. They didn't need naloxone as the methadone because they didn't have respiratory depression as methadone group, but they were more drowsy. And this is, in fact, the difference needed to be paid attention in some crowded, emergency departments such as ours, which receives lots of patients with these complications. I just wanted to mention these two. And I, as Hussein, if there's anything I can explain more, I will be happy to. Thank you.
Great. Thank you so much for joining. We appreciate it. And definitely, that added insight into your work is really helpful. Okay, that was great. Dave, do you folks want to press on? Do you have any other comments now?
No, I think that it for that. So that was kind of setting everything up, and then the next two papers will be discussing kind of their approach to treatment, which I think will lead to a lot of interesting conversations. So we'll start with Dr. Phillip, who I believe has the adult paper, if I'm correct.
Yes, that's right. Hi there, my name is Ari Phillip. I'm one of the toxicology fellows over here at WashU. So I'd like to orient everyone by starting off with a little bit of a case. And so imagine that you're working in the emergency department and you have a 17-year-old, let's say 17 years old, 364 days, could be going to the adult or pediatric hospital, found unresponsive, hypoxic, apneic, and this all resolves with naloxone, and the patient ultimately admits to taking parents' methadone. And so you get this patient, you think to yourself, well, this is someone who's going to wind up on a naloxone infusion, going to the ICU, and you also think to yourself, well, with COVID, we've had patients boarding in our ED waiting for ICU beds for over 36 hours, 48 hours. I'm sure everyone is familiar with this sort of situation. What do you do? Is there, potentially a more elegant solution to this? And so this paper attempts to address that question. So the paper I'm reviewing is the effectiveness of naltrexone in the prevention of delayed respiratory arrest in opioid-naive methadone-intoxicated patients. This is by the authors listed below, done in Tehran in Iran, and this was published in 2013. And so the question that this attempts to answer is that in your population of opioid-naive patients who are presenting following methadone intoxication, does a single dose of naltrexone decrease the frequency of recurrent respiratory depression? So this was a prospective randomized double-blind placebo-controlled trial in patients who were referred to hospital that my understanding of the focus is treats intoxicated patients or poisoned patients, 420-bed approved hospital. All of these patients received routine care, including naloxone for respiratory depression, acidosis, and decreased mental status. And they enrolled 60 methadone-intoxicated opioid-naive patients. So those included were patients presenting with signs of opioid toxicity who ultimately admitted to methadone overdose, or history was otherwise obtained that confirmed this. And they furthermore confirmed this based on exposure seen in the urine drug screen. They excluded patients who had elevated transaminases, who had sequela of their overdose prior to arrival, patients who had precipitated withdrawal that was noted to either naloxone or naltrexone, and patients who had early voluntary discharge. Patients included were those greater than 14 years of age. And so patients were randomized. This was done by the trial administrator providing a bag full of labeled balls, which the administering physician would select a ball labeled either A or B, and then would subsequently, after these patients were enrolled and randomized, would provide a capsule with either naltrexone
or a similarly appearing placebo that had dried milk in it. And so all of the patients were able to receive the trial drug versus the naltrexone versus the placebo. And then the patients were subsequently monitored for different clinical signs, including not just signs of decreased level of consciousness or cyanosis, but laboratory parameters, signs of ventilation, ABG markers. Their level of consciousness was graded, and again, they did look at different lab markers. Data was collected by 5 medical toxicology fellows, and there was ethical oversight of this, and it was all patients were consented, and it was registered with the Iranian Registry of Clinical Trials. So in terms of the baseline demographics of the patients, they were relatively similar. So they ultimately they ultimately included 54 patients. So they were evenly matched, 27 and 27. A total of 6 did drop out. 1 of them for precipitated withdrawal, and 5 of them for early voluntary discharge. And as we can see, there's only one statistically significant difference between the baseline populations, the baseline samples, which is being the placebo group was slightly older, but I would argue not necessarily a clinically significant difference. And then on the left, we see our patients' baseline characteristics prior to arrival in the emergency department. So they were grossly similar in terms of the number of episodes of apnea, the frequency of bradypnea, the amount of naloxone received, and the presenting symptoms. And then on the right, we see the baseline characteristics prior to the intervention, but including their emergency department stay. And this looks at level of consciousness, different physiologic parameters, their symptoms, ABG parameters, and they're again very similar with the exception of the amount of naloxone received in the emergency department, 2.2 milligrams in the placebo group versus 0.6 milligrams in the naltrexone group. And again, a statistically significant difference in the pH of these patients, though the authors do note that this is largely driven by just 2 patients who had significant respiratory acidosis at the time of presentation, which each of them requiring at least 6 milligrams of naloxone. So regarding the patient's outcomes following the intervention, we can see that there are stark differences in terms of the patient's symptoms, their frequency of bradypnea and apnea, their ABG parameters that correlate with this, and then the milieu of treatment in which the number of patients who required ICU level of care naloxone infusion, which none of these patients who received naltrexone went to the ICU. None of them required a naloxone infusion. Only one of them required an additional naloxone bolus, and it is noted that this was for ABG findings as opposed to clinical findings, as the patient was relatively asymptomatic. And we see a difference in the length of stay, 26 hours versus 38 hours in the naltrexone group. These were all statistically significant differences, but I would argue they're fairly stark clinically significant differences. So in summary, we see some slight differences in the baseline population. Some of these are driven by 2 outliers in the treatments they received prior to randomization and intervention. But ultimately, none of the patients in the naltrexone group had loss of consciousness, bradypnea, apnea. None of them all of them could be admitted to a ward setting. So none of them were admitted to the ICU and received a naloxone infusion versus approximately half of the patients in the placebo group were admitted to the ICU, with a large number of them on a naloxone infusion. And then only one of these patients in the naltrexone group even required a additional bolus of naloxone, with the median length of stay being much shorter in the naltrexone group versus the placebo group. So this study was strong in that there is a good effort at randomization, concealment, blinding. I guess some purists could argue that as you're getting towards the end of the 60th patient, if you were keeping track of what A or B ball was left in the bag, it would be, you could potentially, may not be perfectly concealed, but overall the efforts were very good. relatively low dropout, only 10% of the patients dropped out, and they were evenly matched between those two blocks. And relatively large sample, this was collected over a span of 3 months, and they were able to look at a total of 60 patients that were initially allocated. And so beyond necessarily a small proof of concept pilot study, but we were able to look at some larger picture numbers. Now, there were some, I would say, statistically significant differences in the baseline population, but we see that this is, overwhelmed by some very stark differences in the results. Relatively underpowered if we're looking for adverse events. We worry that if we only treated 27 of these patients with naltrexone, we would worry even if one of these patients did have a severe adverse event. And then the important thing in my mind is, I may have caught this, but I did not see any post-discharge follow-up where they looked at coroner data or they saw if these patients were readmitted to other hospitals. Because in these patients for whom some of them being discharged after only 14 hours, the worry would be after naltrexone has worn off, which the authors mentioned, of 50 milligrams should last about 24 hours. Is there recrudescence, especially in these patients who the majority of them took this for suicidal intent and presumably may have taken large amounts. So some things that I wanted to kind of seed into people's minds before we go on to before we discuss this a little bit further and trying to generalize this to our population. They did exclude opioid-dependent patients. One of the patients did have precipitated withdrawal, but in our patients for whom the prevalence of opioid dependence is so high, and we may be missing some of these patients who don't have immediate precipitated withdrawal, would you risk giving them naltrexone and committing them to prolonged precipitated withdrawal? And then how long do you monitor these patients to guarantee safety if you are going to give them naltrexone, knowing that we can't finally titrate it as we can naloxone? And then one of the questions that we'll address later on is, how would you apply this to a pediatric patient population? So my takeaway for this was that in opioid-naive patients who present with opioid toxicity, it's reasonable to consider a single dose of oral naltrexone following reversal with naloxone, and this might have the potential particularly to decrease inpatient resource utilization, length of stay, in patients that are going to be admitted to the hospital. Not necessarily changing the disposition, but in admitted patients to be reasonable to consider.
Great, thank you. And again, please chime in the chat or raise your hand. We're happy to get you on. That was a great summary. What I found really puzzling was, how do we select the patients that are truly opioid naive? I know, like where I work, I would find that extremely difficult. I guess the pediatric population would be the easiest. And then, I was curious for those excluded patients that did a precipitated withdrawal, I wonder what that course looked like and, how difficult a management did that become?
Right. Oh.
Yeah, no, that's a good point. Like I know this weekend we've had a bunch of patients were placed on naloxone infusion, and I had a couple of adult patients, and just thinking about this, knowing we're going to do this at Journal Club, when you give them the naloxone just enough to get them breathing, like I just, even though I thought they might have been opioid naive based on the presentation, you just weren't sure, and so I went with the naloxone infusion, obviously.
Right, exactly. So, Dr. Zamani, you want to go ahead?
Yes, thank you again for the presentation. I just wanted to answer some of the questions that's raised during the presentation. First of all, our center is the biggest referral center in Tehran for toxicology patients. So the patients were instructed to refer again if they had any kind of complications, and none of them referred. So we thought that none of them had problems about the follow-up. I do agree that the follow-up was not enough, but I think it was pretty enough, because if the patients had any type of complications, they would refer to us again. The second one about how we confirmed that the patients were opioid naive, we performed a naloxone challenge test for our patients. We asked them if they were naive, and if they said yes, we performed a naloxone challenge test. The challenge test is and 0.2 milligram, then after 5 minutes, 0.6 milligram, and then after 15 to 20 minutes, a 1.6 milligram of naloxone that is injected. And if the patient does not have any signs of withdrawal, we accounted them as opioid naive patients and gave them naltrexone. The other thing about the children, yes, definitely we have another paper. I think it had, Hossein, you can explain. I think it has also been published. It is about administering naltrexone to our pediatric patients, and it worked very well. And the final question about that the patients that were dependent were excluded. And so is it worth to think about naltrexone? Yes, definitely. We have many patients who are opioid naive and do attempt suicide with methadone. So considering that they are naive, they are not opioid dependent, and they have just attempted suicide with methadone, and many of them do not want to stay in the hospital. I think it works very well for them. And about the dose, I think it is in Goldfrank's toxicology emergency textbook that every 25 milligram of naltrexone, blocks 10 milligram morphine for about 24 hours. So we pretty much, calculated the needed dose for most of the patients, but it was really difficult. And that's it. Any questions, I will be happy to answer.
Great. Thanks, Dr. Zamani. Just one question. I love the naloxone challenge that you administer. Did that pretty much identify all the folks that would have developed withdrawal? So those excluded patients, did they not get that challenge test?
There are some people who are really opioid naive, but they experience some special, they feel dizzy, but they do not show, definitive and characteristic symptoms of withdrawal. So we do account them as opioid naive patients, and we gave them naltrexone and nothing happened. But if the patients had, definitive signs and symptoms of withdrawal, like pain or diarrhea or something like that, and it will happen very fast after administration of naloxone. Yeah, we took them as the patients who were dependent and excluded them. I think it works pretty good. Yeah.
Great, thank you. That's awesome. Dr. Asania, did you want to say something? Okay, I'm not sure. I see there are some interesting comments in the chat. Keith Burkhardt asked, what opioids are the patients exposed to? Yeah, that's a great question. I know, here in the States, we're swimming in fentanyls and, xylazines. We don't know what's coming in the next day. So that would be interesting to know what you folks are seeing there.
Most of the patients, because there's a black market of methadone in Tehran, and it is easier to access to methadone than acetaminophen. It is really easy to access that. Most of our patients, overdose on methadone, and after that on tramadol. During the recent years, morphine has reduced. We don't have fentanyl or any other these types of, opioids.
Excellent, thank you. And I see that I work in a similar place as Kevin Osterhout. another Walmart of heroin here in Chicago. Yeah, absolutely. Oh, and Ingrid Vikas is asking one more time, did I catch that correctly? Your naloxone challenge was 0.2 followed by 0.6 and then 1 milligram. Was that right?
No, it was 0.2, 5 minutes later, 0.6, and 15 to 20 minutes later, 1.6 milligram of naloxone.
Oh, perfect. Thank you. All right, excellent. So we're down to under 20 minutes. What should we do? Any other comments from you folks in WashU, or do we want to press on to the last article?
I think let's press on because I think the pediatric article is interesting for both with what it showed and also because just differences in probably their system versus our system are just interesting to probably talk about.
Great.
Sorry. Hello, I'm Mike Semple. I'm the first-year fellow down here at WashU. My article that I'm going to be presenting is, there we go, a study of the effectiveness of naltrexone in preventing recurrence of methadone poisoning in opioid-naive children. This was once again out of Tehran at the Lagham Hakim Hospital, which I believe is well, they mention in there that it's the only pediatric poison ward in Tehran. And so our objective was, or the objective of it was to assess the effectiveness of naltrexone treatment in methadone intoxicated children. Of note, this study why this came about was there were economic sanctions limiting the supply of naloxone at the time. So they were looking for other ways to treat. This has happened before, or we've thought of different ways we can treat with opioid intoxication. There's some other case reports, one out of Baltimore, where they use buprenorphine actually to treat some opioid intoxication or toxicity. Our methods, this was over a 2-year span from March of 2014 to March of 2016. So retrospective case study, and the data was collected and the charts were reviewed by 2 attendings and 1 resident. And they included kids less than 12 years old that had been poisoned by methadone, and they qualified too if they received naltrexone during their admission. Where was I? But on the next page, we'll see there were 100 that qualified that got naltrexone treatment and had an opioid poisoning. However, 20 of them either were mixed opioids or non-methadone opioids, and we were left with 80 that were poisoned and then received naltrexone. So in scenario 1 is on the first day, they received a naloxone bolus to reverse them, and then some of them did receive a naloxone infusion for some period of time. There was at least 1 that did not receive the infusion, but 7 of them were transitioned on the first day to naltrexone due to the shortage, and then leaving against medical advice was 1 and discharged. Same thing on day 2, but we see more that left with against medical advice. And just to be clear, they were receiving an naloxone infusion up until day 2, and then some point during their second day, they received the naltrexone prior to either being discharged, leaving, or they had to switch over due to a shortage. And then the third group, they received at least 2 midnights worth of the naloxone infusion. At least 1 did receive up to 72 hours of the naloxone infusion, and we'll get to that here in a sec. Let me see, there we go. And then, so here's our demographics and presentation on admission. Relatively equal sexes were poisoned, and then The main thing I noticed here was that the methadone dose that they were poisoned with was actually almost 50% missing, 31 out of 80, so about at least a third. But looking at the data too, from their level of consciousness, the ABPU scale, I think most of us would probably agree that, in looking at the miotic pupils and respiratory rate, that we would all agree they were opioid intoxicated. And then of note too, the VBGs were all done after their first naloxone and bolus, so there probably may have been more hypercapnia than what was actually reported. Yep. Okay. And then this is our clinical characteristics day by day of the naltrexone treatment. I'm going to move this so I can see better up there. And the main thing I want to point out is this is more what I think when we read the title, what we were thinking of day one, people who were transitioned when they were probably still fairly poisoned by the methadone, or would thought to be poisoned due to the long half-life of methadone. And on day one, 7 of them, like I said, got it because there was a shortage. But as we see here under the total cumulative doses, there's some that did not get any from any naloxone, and then also they weren't on an infusion at any time. One of them was on for 20 hours and then also got the naltrexone. Took me a while to actually understand this column because I was like, how do you have hours? And then I realized, oh, that's the infusion. But anyway, and then as we see in the third group, one person did have it for up to the full 72 hours before also getting naltrexone before being sent home. As we'll get to the discussion later, I feel like most of us would probably feel comfortable not treating with naltrexone after a naloxone infusion for 72 hours, unless you were having holidays and they kept recrudescing. But we'll go to the next one. So the conclusions: can naltrexone be an effective treatment for methadone poisoning? I think this does show that it's possible, but there's a few limitations, as I'll discuss in a little bit. And then my thought too with this is, if it is possible, then we can definitely reduce the care needed for our opioid toxic patients and reducing the hospital costs. I know I would enjoy it because I'd get less calls from the PICU in the middle of the night. But some of our limitations, this was an uncontrolled study. We had varied timing of the naltrexone administration, as well as varied timing of our naloxone. And then our information could have been biased as well, with underreporting by parents with the methadone dosing, and also the fact we were missing 31 doses of methadone, or the presumed dose of methadone. And then also this was a single center, but I think that's appropriate too for probably the constraints of where it was done in the country. So I was kind of thinking, can we apply this to our populations? And when if it were to come to a pediatric patient who got into mom or grandma's or someone's prescription medications, where it's, what you're getting and it's a clean, I think it's reasonable that this would be a good way to attempt, it'd be reasonable to have tried the naltrexone as an alternative treatment. But I think to do this as well, we would have to have a little bit stronger of a study, of maybe possibly like a double-blinded randomized controlled trial, where if a patient recrudesced after having their first naloxone bolus, that they get the second one, and then they would be grouped into either receiving a naloxone infusion with an naltrexone placebo or vice versa. And I think that would be the only possible way to really evaluate that. But the other issue too is where we are, this is more of what kids are getting into, is some unknown Ventolog substance or unknown opioid, and we aren't entirely sure what's cut with it and what's mixed in it. And here's our next slide. This is from Dr. Sarah Riley, our friendly forensic toxicologist over across the city at SLU. And they recently published the cutting agents that are found in paraphernalia and powders and pipes that were brought into the forensic lab. Overwhelmingly, there's, not overwhelmingly, but over 50% contain diphenhydramine. That's probably, from what I understand, is because the capsules are easy to take apart. And so if they're even not purposely cutting it with diphenhydramine, their diphenhydramine is getting into the drug. And then, like we were talking earlier, we mentioned xylazine is something we're seeing a little bit more frequently, which is also a drug that is going to cause sedation and Narcan should help or naloxone should help, but it may take larger doses than what we're used to. And that would be interesting. I'm not sure off the top of my head if naltrexone would work. I would assume it would work, but also I would have no idea where to start on the dosing of that. Let me just. So that was the main things on mine was, or the article I read was that really it's that first group, I think, that we can take some, that is what the paper was proposing, that naltrexone could actually treat the methadone overdose. It's just hard to say it's naltrexone when you have couple days of a naloxone infusion and then give the naltrexone. But any questions?
Okay, great summary. Really fascinating paper. And I appreciate Ingrid Vikas's comment that these papers can't be used to discuss OD of street opioids. I mean, it was so interesting what Dr. Zamani said, that methadone's as available as acetaminophen, truly a troubling thing. It's just very different than what we see here in the States. And, we just up the road from you, we early in this pandemic, we didn't have much naloxone resistance, but even, as recent as yesterday, I needed 6 milligrams to reverse an overdose. And you do wonder, it's the xylazine or what else is in there? Just super interesting. And then other comment here. We got a bunch here. So
may I add something, please?
Yes, please do. Go ahead, Dr. Sanian.
Yeah, actually I should add that before administration of naloxone, we should, as Dr. Zamani said, we should try for a naloxone test in order to be reassured that someone who is taking naltrexone is an opioid-naive patient. On the other hand, I personally strongly believe that naltrexone can act much, much better than naloxone in opioid. In attaching to mu receptors. So probably, as you said, if we need more naloxone for someone, and especially if those people are under influence of long-acting opioids, probably or a better remedy rather than naloxone itself. But the main challenge is to exclude opioid-naive patients.
Great, thank you.
Thank
you. The one question that I have also is just, I'm very comfortable stopping naloxone and then watching the patient for 4 to 6 hours beyond that. to have a sense of comfort to let them go home. I guess I'm still, that's a big question mark in my mind. If we use naltrexone, like what is the magic time of observation post naltrexone use before it's safe? Should we be holding them in the hospital for several days? Is there a safer point? Not sure.
I don't have an answer. That's something I would not feel comfortable with as well, just because, I guess though, the other issue I think is the slow onset of naltrexone versus IV or intranasal naloxone. So it would be one thing is if you could rescue with the naltrexone and then they'd be able to say, oh, we reversed it. Now we know this is going to be, we have a half-life of 5 to 10 days. Where with the naloxone, it's more immediate for the reversal, but then if you were to provide the naltrexone, it's hard to say, is that all just from the naloxone that they are now breathing again, or is that now the naltrexone kicking in, or will we have a gap of absorption somewhere in between?
Yeah.
We've perseverated about this a fair bit. We look at should last about 24 hours, but you keep them an extra 6 hours afterwards, you keep them an extra 12 hours. Everyone's pharmacokinetics are fairly different. One of the things that the authors suggested would be at the time of discharge, just giving them an extra dose of naltrexone to help with that safety, give it an added safety profile. But then the question is, if you're giving them an extra dose of naltrexone, do you trust that they would not have otherwise recrudesced, and could they again be at risk for delayed depression? My hope would be that if they recrudesced, it would be much more indolent and that they would have time to seek care. Then I did see in the chat about pediatric hospitals carrying naltrexone. I believe ours does. You can use it for itch in pediatric cholestatic liver failure, and so I think most hospitals should have it. But we've not yet given it. We're kind of waiting for the use case.
And I see Dr. Zamani, did you want to make another comment?
Yes, just one small point I would like to declare. For these patients, we can, calculate the needed dose of naltrexone. I told you about, one small sentence in Goldfrank. We used that formula to, calculate the dose. We are not comfortable with releasing our patients very early either. But I think it depends on the type of the, opioid the patient has overdosed on. For example, we keep our methadone poison patients at least 12 to 24 hours after their, naloxone drip is finished. But for something just like opium, we just, discharge them after 8 hours. And I think that, most of the time you expect the methadone poison patients to have the most severe symptoms during the first 72 hours after ingestion of the methadone. So I believe it's not necessary to, for example, keep the patient for 5 to 10 days or something like that. It's the most important part is, keeping the patient during the first 72 to 96 hours of the ingestion. So for the pediatric patients, we kept them for at least 48 hours in the hospital. But as you said, one of the things that we relied on was the naltrexone dose that we provided them to use during the following hours. For example, we gave them the naltrexone and then told them that you use it the next morning. And of course the opioid dependent patients are not reliable, but most of them cooperated with us, and we didn't have really complications with this. But as we wanted to go further with some bigger case controlled or randomized controlled trials, we had problems with the sanctions and we didn't have naltrexone. So you can maybe do that and we will use your knowledge about that. I think it is quite possible to design a study just like us, but in bigger scale and prospectively in order to withdraw acceptable results. Thank you very much.
Great. All right. Yeah, Dr. Zamani and Dr. Hosseinian, thank you so much for joining us. Couple of interesting posts in the chat by Suzanne Dion about these frequency of methadone exposures increased in peds during the pandemic. And then Keith Burkhart's comment about possible mass exposures. Definitely, I think if we ever get into a shortage situation, as you mentioned in the paper, something we should think about. You folks at WashU have any wrap-up comments?
No, I just, again, like to thank our Iranian colleagues for tuning in. I can only imagine how difficult it is to listen to your papers when you have no idea what someone may say about them. So thanks so much for participating.
Great.
Yeah,
yes, so thanks so much, Ari, Michael, Dave, and Evan. Thank you so much. This was fantastic. Really appreciate it. Our next National Journal Club will be May 10th, hosted by the Indiana group. So looking forward to that as well. But thanks everyone for tuning in, and we'll see you next time.